All right, let's get excited. Let's talk about nephro. You guys like your CMS nephro talks? You good? This is going to be a good supplement to that. When's your nephro test? Monday. Good. So we'll talk a little bit about this. This is a good preparation for that, somewhat. So let's first talk about acute kidney injury. I talk a lot about this because a lot of drugs we have can actually induce acute kidney injury. How do you define acute kidney injury?
Injury the kidney is acute.
Thank you. Yes, you are 1000% correct. What are some things that could be seen as evidence of acute kidney injury? GFR, right? So we're going to see what in GFR? You should see a GFR reduction, right? What else should you see?
High BU and creatinine.
Yeah, BU and creatinine are going to go up, right? And that makes sense. High creatinine does what to your GFR? Remember we calculated that?
Yeah.
Remember GFR, you calculate Cockcroft gall was the common one we talked about for adult patients. Remember serum creatinine was in the denominator. As that goes up, what does it do to your GFR? Causes it to go down, right? So that makes sense. There's that relationship between the two. Also, the big thing to look at is urine output, right? So again, we always want to watch for urine output if possible. Again, that can be difficult in some patients. Obviously, if they have a catheter in place, you can monitor it very easily. If you have a young baby, you can measure their wet diapers, things like that. If you have a teenager, it gets a little difficult, right? Because you tell them, hey, can you pee in this urinal? They don't listen to you. Half the time, they'll just dump it in the toilet or not listen. But urine output's good. And what did I say was like a good urine output for most patients, like adult patients? Usually between 0.5 and 1 mLs per kilo per hour is generally considered to be decent urine output, right? For kids, anything above 1 is considered pretty normal for the most part. And sometimes these kids, you see them diuresis, 4, 5, 6 mLs per kilo per hour, so they can definitely have pretty high urine rates there. But there's a lot of morbidity and mortality associated with this, especially if they develop while they're in the hospital. It's like a hospital-induced acute kidney injury. And the big thing here is there's not a good way to reverse it, right? So we can try to identify early, to identify patients who are at risk for kidney injury, because once it happens, we can't really do a whole lot about it. We just have to give the kidneys time to fix themselves, and sometimes that can't happen. Then you have to kind of replace it. And then how do you replace non-functioning kidneys? You do transplant, but before that, what would you do? Give them machines to do that, right? That's where your dialysis machines are going to come into place. Okay. So big goals here when we're looking at patients with acute kidney injury. What do you expect their hemodynamic status to have occur? You get hypertensive, hypotensive. It's going to get hypertensive in a lot of cases, right? Especially if they're holding on to a lot of fluid that they weren't previously. However, maybe they're hypotensive because they're septic, right? Now again, remembering back to our mantra back in physio, where does the body want to send blood to preferentially? The brain and the heart, right? So again, any other organ can take a hit secondary to those two. So again, if you have a septic patient, right, who's hypotensive because of that, blood flow to the kidneys might be reduced, right? That could be a reason for that acute kidney injury, right? So again, we'll talk about pre-intrinsic and post-renal kidney injury, but think about kind of other things that are going on there, right? Think about the hemodynamic status of that patient there. Obviously, goals we like to do is minimize nephrotoxins. So what are some example nephrotoxins we talked about previously? Vancomycin, what else? Aminoglycosides are a good one, gentamicin, tobramycin. We'll talk about some other examples here in just a little bit, but those are some big ones. And obviously, blood pressure management is going to be important here, whether they're hyper or hypotensive. We'll talk about ways to manage that. Fluid balance, so they can't get rid of the fluids themselves through the kidneys, and sometimes you have to take it off with things like dialysis or give them something like diuretic potentially. And then also looking at the electrolytes, right? So what kind of electrolyte shifts do you normally see with a renal patient? Hyperkalemia is a big one, right? So again, that's a very frequent thing we see in the adult ERs. You have a patient who was scheduled for dialysis Monday, Wednesday, Friday. They skip their Friday session, and then they come in Sunday morning to the ER because their potassium's like 6 or 7, right? So a very frequent thing you'd see that. They're fluid overloaded, potassium's high because they can't clear it through the kidneys themselves. So again, those are all big things for focusing on when you have patients with acute kidney injury. Now, if they're a dialysis patient, they fall under the chronic kidney injury at that point, but we'll talk about that later. Just know there's a lot of different criteria for kind of grading these things. Normally it's going to be based off of the urine output and also based off of the serum creatinine and the GFR. Now, if you remember, we talked about kidney stuff before, and which one do you think is more sensitive to changes, acute changes, urine output or the serum creatinine? Urine output responds much more quickly, right? So again, if my kidneys all of a sudden stop working, guess what? One produces zero urine. What about serum creatinine, though? just like anything in the body, it has a half-life to it, right? So it takes time to get to a new steady state. So you may find you have an injury that will proceed or that will happen, and then you'll see the serum creatinine rise up over the next few days or so. So oftentimes, if you can look at urine output beforehand, you can detect injury before you would see the GFR actually go down, right? Because again, GFR and serum creatinine are going to be intrinsically linked between those two there, okay? And again, as you get worse and worse function, you're going to get worse and worse staging of their acute kidney injury. If you ever see RRT, like on the last slide, that means renal replacement therapy. That would be something like dialysis. Okay. Here's another categories of classification here. Again, based off the same thing, but the criteria might be a little different between the two there. Okay. So looking at the kind of the different types of acute kidney injury we can have something like community acquired, hospital acquired, or ICU acquired. Which one do you think is associated with the most morbidity and mortality? With the ICU, right? Because again, they acquired it while in the ICU. Why are they in the ICU in the first place? Probably sick to begin with, right? Hospital acquired, we'll talk about kind of going hand in hand with that. And then community acquired, usually pretty low though. Now looking at it, which one do you think is much more likely to be like drug related? Probably more often than not, it's going to be in the hospital or the ICU related because we're probably giving them medications that are considered to be nephrotoxic, right? So imagine, for instance, if I'm giving patients, say, NSAIDs in the hospital, right, and that can cause an acute kidney injury. We know for patients that need those prostaglandins. If I'm giving them a vasopressor like norepinephrine to try to increase perfusion around the body, but again, we mentioned the kidneys are going to take a hit, and that causes vasoconstriction, right? These are all things that are going to be considered nephrotoxins you have to watch out for, okay? But again, there's a lot of other reasons as well. It could be volume depletion, could be infection, could be a lot of different reasons why acute kidney injury could occur. Obviously, I'm going to focus a little bit more on the medications here, right? Now, management is really contingent on what's the actual causes, right? So when I say prerenal kidney injury, what does that mean? Dehydration is a really good example, right? Because again, it's not an issue with the kidneys themselves. It's usually due to the fact that we're not perfusing them appropriately, right? Dehydration is a big one that I think of. You know, a patient comes in there, especially dry, right? They're very intravascularly depleted. They're not going to perfuse the kidneys as well. It's a prerenal issue. Does not mean there's actual damage done to the renal parenchyma yet, but it could develop into that, right? Once that occurs, then you have more of an intrinsic injury, which could be due to either ischemia, could be due to toxic insults like medications. And the post-renal could be due to issues like obstruction, right? Now, how do you think drugs could fit into a post-renal sort of kidney injury? When could drugs cause an obstruction? Okay, good. So if you cause some sort of nephrolithiasis, right? So, or a crystalluria or something like that. Remember acyclovir? We talked about how you want to keep patients hydrated because that can precipitate out. Imagine if I was giving a patient methotrexate and that precipitated out. It's a post-renal issue, right? It could either be an intrinsic or, depending on where it occurs, it could be a post-renal, right? Think about it if I was giving a patient testosterone and caused their prostate to grow and impinge on the urethra. It's a post-renal issue, okay? Again, which one do you think is more common we're going to run into? Probably the intrinsic. Pre is going to be like the easiest. It's going to be the one you're going to see probably most often, but you can fix pretty easily just by giving fluids. The intrinsic, though, is going to be the thing you're going to see most drug related for the most part. Okay, at least for our purposes here for pharmacology, this is what we're going to kind of focus on from that standpoint. And again, looking at blood flow into the kidney, this is impaired. This is going to be a prerenal issue. The actual damage is occurring here within the actual nephrons themselves. That's going to be an intrinsic injury versus on the collecting side of things, this is where you can see post-renal. Again, it could be anywhere before the bladder, after the bladder. It all could be considered post-renal. Okay. Because where would the prostate be at in this process? It's going to be below the bladder, right? So again, even though it's below the bladder, it's still considered a post-renal because it's after the kidneys, essentially. And again, when you're looking at this, you can find that a lot of different reasons for this, right? Obviously, you have to do a very good history to determine kind of what's going on here, what comorbid conditions they have. Physical exam is going to be really important to determine, are they hypovolemic, euvolemic, hypervolemic? All of that's good stuff to know. And obviously, laboratory testing is very important. And that will help you to distinguish kind of, is it a prerenal issue, an intrinsic, a post-renal? A really handy thing I learned from one resident was that anytime you see a BU into creatinine ratio greater than 20, you can usually consider to be a prerenal issue because the patient's very dry. Something you can give them fluids for to try to fix that. But again, a lot of laboratory testing will help you out with this. And I'm not going to get specific on the urinalysis and all that kind of monitoring, but just know these are things you're going to use to try to figure out what's going on with your patient. I think these are good examples of reasons why you could see this. Note here as well, anticholinergics. What do you think that would cause a post-renal kidney issue? Huh? Yeah, urinary retention, right? Just because of the effects on the bladder, trying to relax that. So again, that could cause a backup issue, and that could be a post-renal issue, right? So again, think about these different medications and how they could be fitting into this. So, as I mentioned, for community acquired, you see a lot of it secondary to renal hypoperfusion. So this could be due to volume depletion, either dehydration, vomiting, diarrhea. It could be due to sepsis, or looking at medications, right? So how do you think ACE inhibitors can cause a pre-renal kidney injury? Remember what it does to the filtration pressure there in the glomerulus, right? Remember it works on the efferent arterioles. If I get rid of angiotensin II, it's going to relax those vessels, and it's going to allow for less filtering pressure, so you're going to see less actual filtrate make it to the kidney, right? So by doing that, you're causing a pre-renal kidney injury. How about NSAIDs? It's causing vasoconstriction on the afferent side, right? I know I hammered you with this many moons ago. This is why I did so hopefully it would kind of re-trigger some sort of memory in the back of your mind, maybe. No, you're just like, let us go, please. Please let us go. Soon you'll be let go. How about diuretics? Could that be an issue? Straight volume depletion, right? Again, if I take a bunch of Lasix to try to cut weight for something, then I'm going to be peeing all that out, and that can cause a pre-renal issue because I'm now volume depleted. Okay, so kind of think about the mechanisms here. And as I mentioned, for hospital and acute intensive care unit acute kidney injury, typically this is going to be more intrinsic for the most part. Again, post-renal is going to be very specific sort of circumstances, probably the least common out of the bunch for the post-renal. So what are some things that are going to increase your risk for this? Obviously, older patients, they're in septic shock, critical illness, all these things are going to be important to consider. We mentioned some nephrotoxic medications, but I'll get into some more good examples coming up in just a little bit. But obviously, previous history of acute kidney injury definitely going to be predisposing you to future cases going forward as well. So, as I mentioned with pre-renal acute kidney injury, oftentimes this is due to hypoperfusion. Again, it could be with or without hypotension. It depends if the patient is going to be vasoconstricted enough to where they're not hypotensive. They can still be volume depleted and hyperperfusing the kidneys here. Again, as I mentioned, a lot of times it could be due to extra renal losses like GI losses, bleeding, things like that. But for our purposes, diuretic therapy is a big one, right? And, what are the most potent diuretics you have? Your loops, right? So your Lasix, bumetanide, torsemide, all those are going to be very potent diuretics. So again, check the volume status, see what that is going on. And again, for someone who's on diuretic therapy, you can be intravascularly depleted. What is the urine output going to look like? Probably looks pretty good, right? Because you're causing the diurese a whole lot of fluid there, so urine output could look okay, even though they're still experiencing a type of kidney injury pre-renally. Okay. Also think about things like systemic vasodilation, which you see with sepsis, with a lot of this kind of really body-wide inflammatory sort of conditions there. Some cases you could have things like renal artery occlusion, but again, I'm going to focus more on the meds for our purposes. So how do your kidneys respond when you have a pre-renal issue? So the kidneys are detecting low pressure, low filtrate. What's it going to do? The RAS system, right? It's going to activate the renin-angiotensin aldosterone system, try to hold on to more fluid, to try to hold on to more salt, to cause vasoconstriction. Remember, angiotensin II is very vasoconstrictive. It's going to do all these things. It's going to increase salt and thirst intake, right? By which hormone? Antidiuretic hormone. Remember, antidiuretic hormone not only helps with holding on to fluid within the kidneys, but also stimulates the thirst response, right? It stimulates the salt intake. So by doing all those things, we're trying to increase intravascular volume, trying to increase the vasoconstrictive, trying to increase the squeeze, try to get pressure back up. So hopefully if the pressure is back up systemically, it's going to mean your kidneys are going to get perfused that much better. And again, just know these compensatory responses can get overwhelmed, especially if you have drugs involved with this. Like if I have the RAS system getting kicked up, but I'm taking an ACE inhibitor, obviously that's not going to work too well, right? So, as I mentioned, more functional sort of acute kidney injuries with ACE inhibitors and NSAIDs, as we already talked about. Vasopressors, again, these are very vasoconstrictive, which means it will affect blood flow to the kidneys. So you will see things like norepinephrine, dopamine, epinephrine. All those can be considered vasoconstrictors, vasopressors. They're going to decrease kidney perfusion as well. Okay. And for the most part, pre-renal acute kidney injury is generally reversible. Now, if I had a medication that was causing this, say I was giving them Lasix and they had a pre-renal injury, what could I do for that patient? Stop the meds, right? That's always going to be the most obvious thing for any of these cases here. If they're on something that's causing kidney injury, take them off that thing that's causing them kidney injury. Can you always do that, though? Depends on the situation. Maybe not, maybe so. Sometimes you can find an alternative. That's always going to be the first thing you can do. And again, give them more fluid if they need it. Obviously, if they have issues with CHF, they have chronic kidney disease on top of this acute kidney injury, that may not always be the best thing for them, though. So then getting into the intrinsic kidney injury, this is where actual damage is happening to the parenchyma itself. So this could be due to the vasculature, the glomeruli, a lot of different places where the injury could actually be happening here. And this is where, in terms of drugs, we're actually going to see things directly interacting with the cells themselves to cause this, the cell death, to cause actual cell injury. So you can have things like renal vascular damage. It could be related to things like vessels being occluded. Again, not a big thing target for drugs in particular, but could anything decreasing that blood flow, where that tissue can be oxygenated appropriately, that's going to cause issues. You're going to see that glomerular damage is not a big deal, but the most common thing you're going to find is that tubular damage. So acute tubular necrosis is the most common thing you're going to see with intrinsic kidney injury, and this is where most of our medications are going to be playing a role here, right? So again, this could be due to things like contrast agents. Some of our hyperosmolar contrast dyes can cause this, aminoglycosides can cause this, but also think about some secondary things, right? So think about, when would I have really high uric acid levels as a result of medications? We talked about like cancer meds, where you have like a leukemia and you lyse all these cancers, cancerous white cells. What gets released? Well, the purines turn into uric acid. Uric acid can precipitate on the renal tubules and can cause kidney injury, right? Remember that tumor lysis syndrome we talked about? That's where that drug rasburicase comes into play, right? So sometimes those patients will be on allopurinol beforehand. Remember we talked about gout? The same drugs come into play. Now, when do you think myoglobin would be a big issue of clogging up the kidneys, causing this acute tubular necrosis? What drugs could cause that? Statins. Why statins? Rhabdomyolysis. Anyone know any other drugs can cause rhabdomyolysis? We talked about some sleep agents. We talked about some general anesthetics. What can that cause? Succinylcholine, sevoflurane, and this can cause malignant hyperthermia. What happens with malignant hyperthermia? What do the muscles do? They get very tense. They're extremely contracted. What happens to that muscle after a while? It starts to break down. And all of a sudden you have that myoglobin spilling out. That can cause acute tubular injury, right? So again, it's not just the direct effect of the drugs, but it could be secondary issues you're dealing with. We see this somewhat regularly with some of the stimulant drugs that people may be abusing. So you think about things like bath salts are particularly bad for this, but cocaine, amphetamines can all do this, where basically they cause such severe myotoxicity that can lead to kidney injury secondary to the myoglobin they're spilling out. They're now filtering at the glomeruli. A lot of different things can cause this, right? Because again, the kidneys, if you remember, they get a ton of blood flow. They're very highly active from an oxygen needs standpoint. Anything to block that is going to cause some injury. And of course, once you have the initiation of the injury here, you're going to find that the ischemic tissue is going to start to necrose. You're going to have apoptosis of these cells actually occur here. And then at that point, this is where you're going to have dysregulation of fluids. You can't regulate electrolytes, all the stuff you're going to be losing in the kidneys. And oftentimes what you're going to find with a lot of these directly kidney toxic medications, they often cause what we call a wasting syndrome, where they end up wasting a lot of electrolytes. They just can't help to regulate it. So you're going to lose a lot of fluid, you're going to lose a lot of salt, magnesium, potassium, all these things you're going to lose as a result of the injury actually done to the cells here. Okay. Now again, once this occurs, hopefully it can be reversible. Sometimes it may take a while. Sometimes they have to be on dialysis for a while. And hopefully they can recover enough. Sometimes they just can't, and they may be dialysis dependent from here on out. Had a couple of cases of severe rhabdomyolysis secondary to amphetamine use. That patient became dialysis dependent afterwards, right? So it can be pretty severe. Now again, it's not like your typical Adderall. It's going to be like someone who's like using some pretty hardcore crystal meth, right? Anyway, and again, just know that acute interstitial damage can be done with, could be infections, could be autoimmune diseases, but we're going to focus on the medications here. Hopefully it's going to be reversible if it's caught early and managed. And again, with drugs, the best thing to do is just stop the medications altogether if possible. Okay, so I'm going to cut it there. Let me check the board. Any questions? I know you guys are itching to get out of here.